This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
Cardiovascular disease, which in the main is driven by hypertension, is our biggest killer of women and men. And when you combine the mortality from breast cancer, sepsis, prostate cancer, lung cancer, colon cancer and cervical cancer, it is still eclipsed by the number of men and women that die annually in Ireland, some 7,000 from cardiovascular disease.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'll be reviewing changes to the management of hypertension in primary care following the recently published 2024 European Society of Cardiology, or ESC, Guidelines for the Management of Elevated Blood Pressure and Hypertension. To guide me today, I'm joined by Dr. David McConaghy. Here's David.
I'm David McConaghy, a GP in Sallins, County Kildare, and I'm Irish College of GPs Prevention Lead, and I'm part of the HSE team on Integrated Care Programme for Chronic Disease.
In today's show, David discusses a number of recommendations from the 2024 ESC Guidelines, which you may wish to consider incorporating into your approach to patients with elevated blood pressure and hypertension. Some of these ESC recommendations include lower in-clinic blood pressure targets to prompt further investigation, lower targets for blood pressure management when hypertension is diagnosed, and a shift towards combination therapy as a first-line intervention for better patient outcomes. David will also remind us of the importance of risk assessment tools such as QRisk3 and SCORE2 to help us guide management, and, of course, the importance of lifestyle changes for patients. David will also frame these ESC changes in the context of HSE programmes such as opportunistic case finding, the prevention programme and indeed the chronic disease management programme. As usual, you'll find a link to the new ESC guidelines as well as other resources mentioned today and chapter markers in the show notes. And before we begin, please note that this is the last episode in our first series of the GP podcast. We launched back in March 2026 with a bit of a flurry of episodes, including 5 on launch day alone. And some listeners may not have had a chance to listen to all of those. So we're going to select one each fortnight to republish through July and August, before returning in earnest with Series 2 in September. Don't forget to record your podcast listening time as work-based learning in your ePortfolio. And while you're on your PCS homepage, you'll see a poll inviting you to vote for a future podcast episode. Okay, that's it for podcast updates. So let's get back to today's show on hypertension with Dr. David McConaghy. I began by asking David to discuss the new blood pressure targets recommended by ESC and the rationale behind the changes.
The European Society of Cardiology in 2024 looked at hypertension and more specifically at the targets that we should be aiming for as clinicians in treating hypertension. So the first important thing to say is that blood pressure targets have come down. So for the established hypertensive patient who comes to your clinic, in the past we would have said 140/90 millimeters of mercury should be what we were aiming to get below. Now ESC in 2024 are telling us get the office blood pressure under 130/80, or even lower than that, if at all possible. The rationale behind this is when we look at the hard data, 30% of disability-adjusted years have been lost in those with systolic blood pressure between 120 and 140 millimeters of mercury. So if we can drive the systolic blood pressure of a population lower, below 140, as close as to 120 millimeters of mercury as possible, then we can reduce death and disability in this cohort. The other changes in ESC is that when a patient comes into our office and we check their blood pressure, what ESC are telling us now is that if their blood pressure is over 120 over 70 millimeters of mercury, which is, I must accept, quite much lower than we would have been used, these patients are potentially in a group now of what we call elevated blood pressure. And our next step with these patients should be to organise an out-of-office reading, such as a 24-hour blood pressure monitor or their own home readings averaged out. And then after this, if the blood pressure remains elevated on ABPM over 135 over 85 millimeters of mercury, then they are hypertensive and they need to commence treatment.
And David, when I saw this for the first time, I think it is worth restating because it's such a massive change to practice. So it wasn't 100 years ago that I qualified as a GP. And then 140 over 90 was the established norm, for hypertension. But when I read 120 over 70 as being considered normotensive, I suppose I was a little bit skeptical. But you wrote a very useful article on primary prevention of cardiovascular disease in primary care in the September 25 edition of Forum. And you published that bell curve, which projected global disability adjusted life years, which showed that a lot of the disability, up to about 30%, is in that bell curve between 120 and 140. So there's a massive amount of potential morbidity and mortality in that cohort of who we previously would have considered normotensive. Isn't that right?
That's correct. And then hence the rationale then to drive blood pressure as low as reasonably achievable. So the closer we can get to 120 systolic, the less the chances of death or disability in the hypertensive cohort.
So then on that basis, as you've put it, 120 over 70 is the new ESC definition for normal blood pressure. 120 to 139 over 70 to 89 is considered elevated blood pressure, and that's the point at which we begin to consider investigations or should embark on investigations. And then an office reading of 140 over 90 is hypertensive. Is that a fair summary?
Yes, and then what we'd be advocating for in the groups, so this elevated blood pressure group, this is the 120 to 139 systolic, 70 to 89 diastolic, that we'd move then to out of office readings, so an ABPM or home readings over a number of weeks, say a month, averaged out. And then for the 140 over 90s that we see in the office, we should move then on them to, again, similar out-of-office readings, home readings averaged out, or ABPM to make the decision on is this a diagnosis of true hypertension or not.
So again, our threshold for ABPM has really moved massively. You could say it's a paradigm shift, really, from previously I would have considered an ABPM on anybody with an office reading of 140 over 90, and now it's 120 over 70. So our net for who to conduct further investigations has just widened massively.
Yeah, that's correct. And for those who think this might seem somewhat overkill, the global burden of untreated systolic hypertension is massive. After HIV, AIDS, malaria and tuberculosis, untreated systolic hypertension is the biggest cause of morbidity on the planet. Now, we're very fortunate in Ireland. We don't encounter much malaria. HIV, AIDS and tuberculosis are not major public health problems. So therefore, for us as clinicians, systolic hypertension is the disease that we need to focus on and treat for the health of the nation. When you put it into context, cardiovascular disease, which in the main is driven by hypertension, is our biggest killer of women and men. And when you combine the mortality from breast cancer, sepsis, prostate cancer, lung cancer, colon cancer, and cervical cancer, it is still eclipsed by the number of men and women that die annually in Ireland, some 7,000 from cardiovascular disease.
I mean, the numbers couldn't be more stark, really, could they? So it is so super important to take this new threshold on board and to seriously consider integrating it into your routine day-to-day practice. Apart from what we've already mentioned, the out-of-hours blood pressure in terms of a HBPM or an ABPM, you also mentioned in your notes the idea of undertaking a formal CVD risk profile and giving the patient lifestyle advice. Are we moving towards the opportunistic case-finding territory at that point?
Yes, I suppose it's very prudent to think that hypertension is one part of the puzzle. In all these patients also, it's important to do a score such as a Q risk or a score. Many listeners will be familiar with the Q risk because it's built into our GP software systems and into our CDM software. So this is where we get together data on height, weight, smoking, body mass index, and medications, other comorbidities. And it's put into a calculator then that will give us a figure of their chances of having a cardiovascular event in the next decade. And these are useful and important as well, and advocated again by ESC.
And to prepare for our conversation, David, I did a quick bit of digging around Q risks and scores, and I appreciate the Q risk is it's enveloped in the CDM program, so GP colleagues will be more than familiar with that scoring calculator. But for somebody who comes in with an elevated blood pressure, Score 2 is a reasonable one, I guess, to consider. It's very quick, actually. It's considerably quicker than Score 2 from my toying around with it on MD Calc on that website. And if you want to just get a quick assessment of somebody's potential CV risk status, it can be a useful one to utilise as an alternative to Q risk. Would that be fair?
Yes, again, the ESC would advocate for score, and some authorities would say it's better suited to perhaps a European and therefore Irish population. However, Q risk is built into our software, and I think the main thing here is that I'd be advocating for GPs and their teams to be using a calculator of some sort, and Q risk or score are both acceptable. And again, it's often we find that because it's embedded in our software, we're probably more likely to use Q risk because of the ease of access. It means you don't have to move between platforms on your PC during a busy day.
That makes sense. Once you've done the score for somebody, whether it's Q risk or whether it's Score 2, if the risk is above the threshold of 10%, I understand that threshold hasn't changed. What happens next?
So you've perhaps give a scenario where you have someone who's got elevated blood pressure. You've done an ABPM or out of office readings. You've worked out that they're still in the elevated hypertension category. This is 120 to 139 systolic, 70 to 89 millimeters of mercury diastolic. And you've done a Q risk or a score on them. It's above 10%. ESC are then telling us, give these people lifestyle advice. So exercise, low salt diet, sensible alcohol, weight loss if required, and then to get them back in 3 months again to see if they've made the lifestyle changes, and if then their score or their Q risk has got down below 10%, then you'd monitor them on an annual basis, what I'd advocate for. But if after 3 months their score remains above 10, treat the risk factors, whether that's the LDL cholesterol or, more importantly, the hypertension.
So, just to interject there for a moment, could I find myself then in a scenario where I have a patient who's, let's say, 50 years old, who has a blood pressure of 130 over 80, let's say, on an ABPM. Previously, I would have said, well, that ABPM is somewhat reassuring. You know, they fall below that threshold. But now, if it's 130 over 80, but combined with the CV risk factors, putting him at a risk of greater than 10% or her at a risk greater than 10%, I'm going to go ahead and start an antihypertensive, even though they're not below that solitary threshold for hypertension.
That's right. And I think that the idea behind this is, again, you look at your 50-year-old patient, John, that you mentioned, they're, based on today's figures, they're going to live into their mid-80s. They have 35 more years of good living. We want to keep that disability free. And the rationale, again, is to modify these risk factors now. As I often say to my patients, we're doing something positive now to stop something negative happening down the line. And most people buy into this.
You're reminding me of my own self-talk, David. I'm recently returned to the gym and I keep telling myself about my health pension. As opposed, it's working so far. It might not work for much longer, but we'll move on from that. So, look, this is to my mind at least. This is massive. This is a total sea change in potential management of our patient cohort for the good, which is what primary care is all about. And then the next piece, I suppose, that jumps out at me is when you have established hypertension, as you said, you're going to bring people back regularly as part of that. But the targets have become more aggressive and the management has become more aggressive. Could you speak a little bit more about that, please?
Yeah, I think the take-home message from ESC on established hypertension, so once the diagnosis has been made, treatment's been initiated, is that when you get your patients back 6 monthly, 12 monthly, as we do, is with the office readings to get the systolic under 130, to get the diastolic under 80, and preferably closer to 120 if possible. We know that office readings tend to be about 10 millimeters over real world readings. It's the white coat effect. We're all familiar with that. And the act of monitoring or measuring any variable in science, the act of monitoring it actually has a bearing on it. So again, this is a sort of a change in that we've seemed to have pulled down the threshold by another 10 millimeters. But again, the hard data from ESC supports this. Again, lower you get the systolic blood pressure, that reduce the chances of disability and death.
And you mentioned then about management and obviously, that more aggressive approach. The way my approach would be typically, at this point in time at least, would be to start an agent, based on the guidelines, maybe an ACE in the first line, an ACE inhibitor. And then if that's not controlling, I tend to add a second agent, i.e. a calcium channel blocker, rather than titrating the ACE inhibitor to max dose first. And I was taught that you do that, you bring in your combination early to minimize the risk of side effects by over titrating a monotherapy. Is that still the approach, or do I need to realign my practice?
The feeling now is that we need to use combination therapies from the off. And 2 agents at medium doses have a greater effect than 1 agent at a maximal dose. So again, and you mentioned some agents there, I would use an ACE or an ARB plus either a thiazide or a calcium channel blocker in medium doses as first-line treatment. And the rationale behind this is that you will get people to below target more quickly as well. So, no, I think take-home message here, kick off the treatment with combination therapy.
Am I reasonable in saying that's another pretty big change as opposed to starting low and going slow?
Yes. And again, it's a change that I've made in my own practice as well over the years, is that perhaps before where I would start off with, say, amlodipine at 5 milligrams, review the situation after 6 weeks. Now I find myself, again, using the dual therapy with the whole idea of getting it controlled as quickly as possible.
The other voice in the back of my head that's beginning to shout, David, that I'm going to share with you is audit, audit, audit. This seems like pretty fertile ground for a 2025-26 audit and beyond.
Yes, again, I suppose the really good way to reflect on our practice is to do this. And again, this would be a very good audit for an entire practice to do as part of their PCS requirements. A simple way maybe to approach this is print up a list of all your patients that you've coded for hypertension, and ask yourself the question: have they had their blood pressure checked in the last 6 months? Is it below target? You could look at other things. Have they had a 12-lead ECG done? Has it been ABPM confirmed? For your own interest, you might look at the number of agents they're on. And again, your gold standard to compare is widely available, easily available on the ESC website. And again, it's a good audit to do, in my opinion. And I'm not saying that because I have a special interest in hypertension, but because it's one that it's a common condition, an important condition, and the whole team could be brought in across the board. Registrars, medical students, if you have them with you, GP nurses as well. So know that you might find that a useful activity to undertake as a practice for if you were hunting around for an audit for PCS.
And I think one of the, you might say, even the hazards of primary prevention is that sometimes I say to medical students, nobody's ever come into my practice and shaken my hand to thank me for the heart attack they didn't have because they were appropriately managed. But we do know that at population level, by implementing these changes and by becoming a bit more rigorous with our blood pressure control with our own cohort of patients, we can make real impact at population level on morbidity and mortality, as those early numbers you so clearly outlined indicated.
Indeed, and again, this is one of the things that we, on the subject, of prevention, as a well-known public health doctor who says, nobody comes up and thanks you because they didn't get diphtheria. And again, it's unlikely that in a silent condition such as hypertension or some of the other chronic diseases that your patients will come and say, thank you because I didn't have a stroke, or thank you because I stopped you from coming to harm from your smoking that you told me to give up. But I suppose we have to be happy and content ourselves at the end of a career, look back and say, well, I followed to the best of my ability the guidelines, the best public health, the best specialist advice. I implemented it in the trenches of general practice, and be content with that.
Absolutely. You mentioned so far, you've talked about the change in the thresholds for further investigation, and we've gone into some detail about ABPM and HBPM. Is there a role for ECG as well?
Yes, I think in established hypertension, there is a role for an ECG, and I like to do 12-lead ECGs on my patients with established hypertension to look for mainly two things: a dysrhythmia, such as AFib, and then signs of left ventricular hypertrophy. So this would be a useful test to do, along with the other tests, such as certainly in the under 40s, checking urine for albuminuria or protein creatinine ratio, using EASE to look at renal function, full blood count for anemia, lipids obviously, and HbA1c for diabetes. Again, all very useful tests, and the thyroid profile as well. Hyperthyroidism sometimes can present as hypertension as well, but I imagine there'll be other symptoms as well. But these will be, along with ECG, will be important tests to do.
Is it reasonable to offer patients an annual ECG and ABPM to monitor?
Yes, it would be the answer. I think that at every opportunity, hypertension is a risk factor for atrial fibrillation and left ventricular hypertrophy. So I think that certainly use of a 12-lead ECG at an annual checkup would certainly be a good use of resources here, because to pick these conditions up early will sort of mitigate against the downstream pathology and misery that they can cause.
Okay, thanks, David. I think we've covered the core key points for GPs out of this new and important ESC 2024 guideline. But of course, there will be times when we don't meet our therapeutic targets in primary care. At what point should we consider a referral onwards to secondary care?
It's a very good question, John. The good news is that GPs will manage to get 90% of our patients below target. But we know certainly from the research that 10% of patients remain resistant. And so I would look at referring on two groups. Firstly, the young hypertensive, so someone who diagnosed with hypertension under the age of 40. I think the advice that I give here is start them on a calcium channel blocker, which won't affect the renin-angiotensin system, for further investigations, and refer these patients on to secondary care. The second cohort are those who have a diagnosis of hypertension and they're on 3 agents at maximal dose, including a diuretic, or they're on the highest doses of 3 agents that they can tolerate. If they remain above target, they need to be referred on to secondary care. The reasoning behind this is that they may have a secondary cause for hypertension that hasn't been picked up, and secondary care is well placed to investigate that. And also, even on 3 agents, including a diuretic at maximal dose, some patients don't reach target, and there are other therapies such as renal denervation, which has come back into the ESC guidelines, that could be utilised to help these patients out.
And aside from renal denervation, which, as you said, is back in vogue now, are there any other potential novel or future therapies that GPs should potentially be getting excited about, or not so much?
So when we stand back and look at hypertension, it's a polygenomic entity. So developing a novel treatment can be quite challenging. And we do notice in the world of cardiovascular research that there's a tendency now for pharma to look towards heart failure and lipids as the areas that they're investing in. The good news is we have many good agents to treat hypertension, and the vast majority of our patients will be controlled with the agents. Renal denervation has come back into the ESC guidelines, and this is useful for some of our resistant patients. But I think as an Irish general practitioner, the most exciting thing is the chronic disease programme. Opportunistic case finding allows us to find these patients with hypertension earlier and make interventions which can be life-changing before there's downstream pathology happens. And the prevention programme now means that our patients with hypertension get checked up at least once a year, which can only be good for them as well.
Okay, so I guess there's a real re-emphasis of that point, that as primary care providers, we can deal with the lion's share of this really potentially serious risk factor really competently in most cases ourselves, which is a heartening message.
No, so I suppose if I have to sum up what, key messages on hypertension would be, it's a common condition. It's a really important condition. Look for it and treat it to below target. Use combination therapies from the off. Aim for an in-office target of under 130 on 80 on the established hypertensive. And in other groups where you suspect hypertension and elevated blood pressure, get an out-of-office reading, an ABPM or home readings. Don't forget that the patients under 40 will need specialist intervention. In the elderly, ask about orthostatic symptoms and do deprescribe if that is happening. We can't have our older and frailer population having an increased fall risk. And in the resistant hypertensive patient, do try your best to maximise out on 3 agents, including the diuretic. But if this fails to get them below target, do refer them on.
Okay, well, we've been speaking for short of half an hour now, David, and you've really given me plenty of food for thought and plenty of new pivot points for me to take in my own practice for my cohort of patients. So I'm really grateful of your time today and for taking the time to give this really useful overview of the ESC 2024 guidelines as they apply in general practice in Ireland. So thanks again.
Thank you, John. It's been an absolute pleasure.
Many thanks again to Dr. David McConaghy for speaking to me today. And don't forget to check the show notes for chapter markers and links to resources. If you've any comments or feedback on today's show, or indeed suggestions for future episodes, please let us know by getting in touch at podcast@icgp.ie. And don't forget to record your listening time in your ePortfolio and vote for a future episode on the PCS homepage. And that's it for today. And indeed, that's it for season 1 of the GP podcast from the Irish College of GPs. Thanks so much for listening. Have a lovely summer and see you in September for season 2. Until then, take care.